Hello, everyone, and thank you for joining us for today's Industry Leader Briefing. This is Kate Berry, CEO of National eHealth Collaborative, or NeHC. NeHC is a public-private partnership working to advance nationwide health information exchange, including educating stakeholders about health information exchange and related topics. I'm very happy to have Holt Anderson with us today for our Industry Leader Briefing. Holt heads up the North Carolina Healthcare Information and Communications Alliance, or NCHICA. We are very much looking forward to hearing from Holt, as well as to having an interactive Q&A session. I will introduce Holt in just a moment. He's going to talk today about interoperability strategies and the Nationwide Health Information Network Exchange and his experience connecting with the exchange. Next slide, please. Just briefly, we have expanded our education program and rebranded it recently as NeHC University. Our class offerings now provide a broad and deep view into the rapidly changing health IT landscape. Next slide. Before I turn it over to Holt, I'm just going to give you a quick overview of the NeHC University. As part of our expansion, we recently created the NeHC University Advisory Council. And as you can see from this slide, the Advisory Council has representation from virtually every segment of healthcare: physicians, hospitals, payers, academia, government, and more. The Council will help us shape the curriculum, serve as faculty, help recruit faculty, and provide additional advice to us. We're very happy to have them as part of our extended team. Next slide. Here's an overview of our new programs. We're offering industry leader briefings, such as this program today, Health IT Orientation, which will be quarterly, Health IT Policy and Standards Committee quarterly updates, special guest lectures, Health IT Trends, and Spotlight Learning Series, which are three class programs, and a continuation of our NwHIN University 300 series. Coming up on Monday, we have NwHIN 304, which will cover health IT success stories from the patient perspective. So we have a couple of patients joining us to talk about their experience on Monday. Many of our classes can be viewed on our website at nationalehealth.org. Next slide, please. So during today's presentation, please feel free to enter your questions at any time on the right-hand side of your screen. And you can also email us or tweet a question or comment on our Facebook page. Now I am pleased to introduce Holt Anderson. As I mentioned, Holt is Executive Director of NCHICA. NCHICA is a private nonprofit consortium of healthcare providers, payers, corporate partners, professional associations, and government agencies. NCHICA was formed in 1994, and the mission is to improve health and healthcare in North Carolina by accelerating the adoption of information technology and the enabling policies. So in addition to his day job, Holt serves on a number of councils and committees and boards. The state of North Carolina, he's the state of North Carolina lead for the Nationwide Health Information Network Phase 1 architecture prototypes and Phase 2 trial implementations, and current emergence implementation funded by contracts with the HHS Office of the National Coordinator. Holt also serves on our NeHC Board. So at this point, I would like to turn the virtual podium over to Holt.
Kate, thank you very much. I very much appreciate the opportunity to speak today with this group across the nation, and hopefully you're seeing my slides on the screen now, and I will walk through these. It is an honor and somewhat intimidating to talk to the groups that have been on these presentations before. I represent an organization that's been around a while, and hopefully there's some things that others may find useful in this presentation, and we certainly want to hear your questions at the end and hope that I can respond to those. I just want to check to see if you're seeing the today's environment slide, Kate. to make sure?
Yes, we have the header side using collaborations to the header slide.
Okay. And I've changed, so let me make sure I'm currently the presenter. And do I have control now?
Yeah, we think, yeah, you do. Holt, you should.
Okay.
Let us know if you need help.
Now, today's environment's like. Well, in the 16 years that I've been working specifically in healthcare technology and policy, I've never seen the system under more stress. It's financial stress, the budgets, the needs to do things within these enterprises to convert to ICD-10 for the new NPRM that's out on accounting for disclosures and trying to put together comments for that as to the impacts on the sector. Upgrading these clinical systems and changing the workflows, there's a lot of flux in the system today as they're getting ready for meaningful use and acquiring practices and setting up for ACOs. I think the thing that we may be missing as we're focused mostly on our enterprises, regions, and states is how this is going to impact us in the future from an interstate exchange, making sure our technical and policy standards we may adopt in our enterprise or in our region or our health information exchange will work when we need to exchange across state boundaries. And then, of course, the dollars that are associated with the stimulus funding to achieve meaningful use, you've got to get your electronic health records in place. And you've got to be able to exchange information in standards-based ways. And yet to be, coming up in a future stage is, what about quality reporting? And are our systems going to be ready? And making sure all of this is in sync. And then the planning uncertainties. Where are ACOs going? And thanks to NeHC University for putting a session on regarding that yesterday. And then where is the federal healthcare legislation going to go? Where is Congress going to go? Where is the administration going to go? A lot of these are creating this stress within our system and within our organization. Well, a few years ago, since we collaborate a lot across competing enterprises who come to the same table, one of the comments from a participant one day was, this is my monthly therapy session. I'm here with my peers, and we're all working and facing these problems, and it's really nice to be able to share experiences and solutions and who's doing what, how you're approaching this. So at NCHICA, I think any success we may be having is because we've been able over these 16 years to create a trusting environment, to come together and develop consensus-based approaches, to take what the clinical needs are from our organizations, and then figure out from a policy standpoint, how do we get information from one place to another place in a secure fashion, and then inform clinical decisions. So we're making better clinical decisions. And I like the National Business Group on Health once said, quality costs less. Well, if we can do things in terms of technology and policy to enable better decisions, then we're going to gain those efficiencies and then we're going to be able to comply. So our work groups and task forces are all about looking at consensus-based approaches to adopt these technology standards in a uniform way across enterprises as they emerge. And then as we figure out things like breach, what kind of risk mitigation strategies do we need to work on? And currently we're worried about mobile devices, iPhones and iPads that all the doctors are adopting, and they're coming to the IT staff and say, will you support my iPhone and iPad? And what about the ability to secure this information and encrypt it? We, as a group, develop a lot of model documents, such as a business associate agreement that's really used widely, and template policies and procedures for mobile devices and removable media. And we engage around our tables, business partners, in prioritizing system upgrades and enhancement, because normally they're focusing on a customer one at a time. But if we can help and assist them, they can be more efficient in deciding which priorities and upgrades need to come first. So that's very helpful. And so our stress reduction strategy is really, let's get together and figure this out together, because one person said, well, when I'm on the stand in front of a jury, I can say this is consistent with the way we're approaching it as a community. What I'd like to do is reiterate just briefly what Kate said. We were formed in 1994, so we have some history of collaboration as a 501c3. This mission we take very seriously of improving health and healthcare by accelerating the adoption of information technology, but very importantly, the enabling policies. We probably spend at least 50% of our time working on the policy side of things. It's not a technology problem. It's a policy and making sure that we've got things working so that we can be interoperable on the policy side. And I might say we're very happy to say, just in the last day, the North Carolina General Assembly has passed 2 bills, and they're going to be on the governor's table to sign. One is to create an opt-out policy for the state of North Carolina to enable health information exchange. That means that patients will be informed. Their records will be accessible through a statewide exchange, and they will be listed in a directory lookup service unless they opt out. And if they opt out, it will not be there. And the second one, very significant, and a lot of work was done on this, was to conform our statutes that have been created over decades, mostly related to paper records. The next bill is to conform those statutes with HIPAA. And so we're very happy that we think we're cleaning up the policy landscape in the state of North Carolina, and a lot of credit goes to folks working with a task force, working with the North Carolina HIE, who have done that. Just a terrific amount of work, and we're very proud. We look at integrating these clinical needs with the policy, technology, and adoption standards, and currently we're getting close to 250 members that really represent the spectrum of the healthcare sector. And grouping up and working together, we think, is the solution to interoperability. And over the years, we've taken on projects as a community. Back in the mid-90s, we worked on model privacy legislation for electronic records and signatures. And there was a law passed, and actually got involved somewhat with the HIPAA law as it was emerging. In 1999, we passed a law in North Carolina that no longer made paper records and pen and ink signatures, wet pen signatures, required for any legal purposes in the state. And that was in 1999. We then, our members came together in a period of a very few months, about 3 months, stood up a secure web-based immunization registry, bringing together the immunization records for Blue Cross Blue Shield, Kaiser Permanente, and the state, and worked on that. It was supposed to be an 18-month demonstration pilot. It took us 7 years to shut it down until the state got a registry because people found it useful. And then we got into the area of situational awareness in emergency departments in the early 90s, and currently the state of North Carolina, through our Division of Public Health, reports about 25% of the biosense data to CDC, the private biosense data that they receive nationally. Our work on the nationwide health information network, and then we're going to focus on that next, really began in the 2004-2005 timeframe. I'm going to show you at the end of the presentation some model tools and policies for compliance that are available to the public on our website, and we'll show you where to find that. And then we hold educational workshops and conferences to take all of the lessons we're learning from these projects out to our community and to anyone else who would like to be informed. We have supported our statewide HIE Regional Extension Center, the HIT Workforce training programs in our state that are part of the HITECH Act and are part of that. Now to focus in a bit on the Nationwide Health Information Network, we're very happy to have joined with a number of our members in Phase 1, the prototype architectures, and Phase 2 with trial implementations. And our major partner in that was IBM, who was a founding member of NCHICA and has a major presence in North Carolina. And you see on the screen these provider organizations that came together and to get a vision of the future and actually work as participants in these first two phases. The phase we're currently engaged in is emergency implementations, and we're working with the Western North Carolina Health Network and Data Link to establish this, and I'm going to talk a bit more in detail about that. In the emergency application, we were asked to find a community that was currently sharing information. And these 16 hospitals, and a few of these names have changed, there have been some mergers and other things, but essentially there are 16 hospitals in Western North Carolina, including the Indian Health Hospital in Cherokee, that agreed about 6 years ago that for clinical purposes, when people come into an emergency room, they would allow one of the hospitals, if the patient was in one hospital, they could get an authorized, authenticated access to the records at any of the other 16. So the Western North Carolina Health Network, which is in the far southwestern part of our state, established the Western North Carolina Health Network and the Data Link project and uses MedSeek as a portal vendor to provide a view into the records of these other hospitals. Well, at that point in time, we started looking at that Western North Carolina Health Network as a potential opportunity for this emergency application. And when we did a first look, we observed that the Asheville VA Medical Center that has 30,000 people, veterans, that they serve, was the only hospital not connected. In the initial view, before we had any confidentiality agreements, the hospitals could identify about 4 veterans a day who showed up in an emergency room at one of those 16 hospitals without any access to the VA records easily. Based recently, once we signed confidentiality agreements and could match the master person index for the VA against those encounters for those individuals who had been seen in one of those 16 hospitals one or more times, we found out that there were 9,221 distinct veterans who had visited at least one time in one of those 16 hospitals over the last 12 months. So we're building a business case as to why this connection would be helpful. So once we get this project done, there are other VA facilities in North Carolina, and then certainly the DoD has a major presence here as well. So we certainly want to leverage this project and our lessons learned to move to the future. Okay, so what have we done? We started with the Western North Carolina Health Network and their Data Link project, and they're sharing information and have been for 5 years, a significant number of encounters. We have the Charles George VA Medical Center in Asheville, North Carolina, in the Great Smoky Mountains, who have a population of about 30,000 veterans that they serve. They, of course, are a part of the Department of Veterans Affairs and are part of the VISTA system. They're able to share records within the VA today. Well, the VA is part of the Nationwide Health Information Network. They're a participant there. In fact, they're participating with a number of other communities across the nation and sharing information. Hampton Roads, Virginia. They're beginning to work in the Northwest up in the state of Washington and with some of the other nationwide participants in a project called the Virtual Lifetime Electronic Record, VLR. Okay, so what we have is they were connected to the Nationwide Network Exchange, and NCHICA came into the picture and established a gateway, a switch that is a standards-based approach, connect, and we'll talk a little bit more about that, allows us then to connect to the nationwide network and all of the policy pieces done there. It also now provides a connection into the Western North Carolina Health Network so that the data can flow between these in an authorized, secure manner. And so I'm pleased to report that we went into limited production on March 31st. And I hope some of you are in the queue to get onboarded to the nationwide network. So I want you to be aware, in some of this presentation, be aware of the intensity of conformance, interoperability, and partner testing that all has to take place before any protected health information is risked within this connection. And so we've had teams from NCHICA, from the VA, from the West North Carolina Health Network, MIRTH, and NEHC, who have been working very diligently now for a significant number of months to make this come about. We have some planning underway for public announcements and demonstrations in Asheville in July. And by the way, a disclaimer is I'm not speaking for the VA or ONC here in this presentation. We will have some plenary and breakout sessions at our conference in the wonderful Blue Ridge Mountains of North Carolina at the Grove Park Inn in September. And if any of you are sort of in the pathway, we would invite you to come, and there's information about that conference on our website. But it's a nice place to be, and we would welcome you there. So where do we go from here? Okay, so we're up, we're in limited production. Sustainability is an issue for all of us as we implement technology and we're beginning to share information to serve clinical needs. Well, so what? This health information exchange is a cost. It is an expense. So we really need to demonstrate the value of this to our community. And so once we have this gateway, this one particular instance set up and running, how do we load this utility, and think of the gateway as a utility. We need more traffic. We need to engage the Social Security Administration, Indian Health Service, Public Health, DOD, CDC, to run more traffic through this utility so that the cost per transaction is less. And then what about administrative transactions? You know, I was talking with a lab company. They would love to get eligibility information better to make the claims process more efficient. And by the way, if that were running over this connection, this nationwide exchange, wow, that may encourage them to think about joining in, using the exchange as their means of working with clients. Well, we don't know that. So a lesson learned for those of you out there who may be starting down this path and think that, well, my state's setting up a statewide HIE network, and that's great. I can just hook up to it. What you really need to realize, and I think which came a lesson that I've learned personally, is, boy, the cost of this is more on the enterprise and the community HIE side than it is on the gateway connection to the nationwide network. Building these interfaces and the adapters, especially if you're a federated model, that means you may have a number of different enterprises out there with different systems on different versions that have got to be in sync. And bringing together a master person index across those various systems may be a challenge. So you certainly want to look at that. I think a single enterprise is much easier to establish a gateway because they've already got their MPI built and they're able to work with one system vendor. So if you're looking at federated models, that's one lesson learned I think might be helpful to you. ONC is working very diligently to streamline the onboarding process. heretofore it's been mostly a manual process, and we just can't go forward with that. And ONC has got that one in hand and is really working very hard to make that happen, so that those of you who follow us that burden should be eased. I would say start early now, understanding the onboarding process and this data use and reciprocal support agreement, the policy side of this, because these requirements, these expectations and responsibilities from a policy standpoint you have to agree to before you're allowed to participate. You will have to flow down to your participating organizations, practices, and others in your community, your health information exchange community. So start early there. Now, with the gracious assent of the Office of the National Coordinator, ONC, again, I do not speak for ONC. I'm merely providing my observations of some slides that they have used in the past to give you a sense of this. That the Nationwide Health Information Network is a set of services, standards, and policies. So remember, it's services and the standards and the policies that enable this secure health information exchange over the internet that creates this trust fabric. That it allows us to be interoperable in this group setting. Exchange, one of these parts of the Nationwide Health Information Network, is a query response model. It is a push and a pull model. It allows a really robust exchange of information where there's a lot of transactions going, and it does not require multiple point-to-point interfaces and exchange modalities. So you can group up and send lots of transactions through this. Nationwide Health Information Network Direct Project allows more of a simple push model. When you know the address you want to send it to, you're very confident who they are, and you know their address, and you can send it securely to them under the direct model. This exchange works under this common trust agreement, this data use and reciprocal support agreement, and is governed at this time by a coordinating committee made up of the participants within the Nationwide Health Information Network Exchange. And it sets forth the rules and the policies and procedures that anyone who is connected in an exchange mode must abide by. I will point out, the federal agencies are coming to the table, and this is their major way that they're going to be doing business in the future. So I would say to everyone within their state HIEs and other places, please pay attention to this, because the federal agencies are going that way. More of the major entities across the nation, like Kaiser Permanente, are going this way and are committed in this direction. I think it's a very important thing to pay some attention to. So the Nationwide Health Information Network itself, both on the more robust end of the spectrum of exchange and the less complex model of the direct project, is going to provide us interoperability in this country, and one that's certainly needed if we're ever going to achieve more informed and educated healthcare and be more efficient in the long run. Connect is software that the Federal Health Architecture Group, the federal agencies came together and said it doesn't make any sense for us to each develop a gateway. So let's join forces and contract out for this development. And so they've built this open source tool that is available, and they've just announced today version 3.2 of that with some new features. So you might want to pay some attention to that tool. It is standards-based, and you don't have to have the Connect. You can modify it, or you can use your own homegrown gateway as long as it complies with the federal standards, the network specifications and standards. Very pleased that today we have 13 organizations that have executed the DRSA, that have been onboarded and tested, and that are participants. In the queue, there are a number of organizations, including 14 that are partnering with the Social Security, a number of these DOD, VA communities called VELR. There are 56 awards that have been made under the state HIE cooperative agreements. Those are the stimulus funded for statewide HIE. And then there are 17 beacon communities who may play to some extent in the exchange activities. So there's currently a group of us that are there. There's a significant group lined up to be going through this process and making it very efficient is what ONC is working on now. Eligibility requirements. Currently, you have to be a federal agency or non-federal entity with a federal contract. And these might be these contracts through the statewide HIE or a contract with the Social Security or with the VELA community. And then you've got to have an infrastructure somewhat in place and the governance structure who can be a party and be liable and responsible for signing the DRSA and enforcing those responsibilities and obligations under the DRSA. The DRSA itself is a tool. It was first approved a couple of years ago. All of the parties that you've seen as current participants have signed this agreement and abide by it. There's a new version that's going through federal clearance that will be out shortly. No major changes in that. All of the current participants will be obligated to sign the new agreement. And it slows down certain obligations and responsibilities. So this document is available through the Nationwide Health Information Network website. So onboarding, it's a process. There's several steps before you can be a participant. You have to prove that you're eligible, that you have the governance structure, the technical capabilities, you have an existing contract, and you're ready to go, and you agree with this ability to sign the agreements and abide by these terms and conditions. You first are qualified, and the coordinating committee I mentioned earlier, that is the current governance structure for the exchange, will make a determination. Yes, they're eligible to begin the validation process. So once you've got your systems in place, you've got your adapter, you've got your interfaces built, you've got your gateway up and ready for testing, you will go through a conformance testing and a reliability testing. And then the next steps are to bring you active, to actually move you to production. And so the coordinating committee will see the results of the validation process, will give an approval, and you're ready to go live. Except that, and this is my addition to this slide, this ONC slide, is before you go live with a partner, they're going to want to know that you are compatible, that your send of a C32 or summary patient record, they can read, and vice versa, and are they configured properly? And that partner testing is a significant step in actually going live and exchanging protected health information. So really pay some attention that is, and get in sync with your partner early so that you're building a critical path method of scheduling, and you know as you go down this testing path that you've got to have a testing with your partner and understand what that is. Let me see. Make sure I'm in sync here. Okay, so the process overview. This is just a roadmap. Certainly these slides are available, so you can take this later and adapt it to your own internal steps that your enterprise or region or state will need to take. It's very helpful, and I think you can fill in some more details here in your dependencies and prerequisites that you have to put in place to be able to make it to the final stage where you're in production. So getting started, get your business case. As we did understanding there are 30,000 veterans in Western North Carolina. Their major focal point for their care, the VA hospital, was not connected to the other 16 hospitals in the region where these veterans are being seen. So that's the starting point, is we're here to serve patients, to provide clinical care, and also to make sure that their health is where it ought to be so that the information is at the point of clinical decision making. Then to look at the specifications for onboarding and for getting to an interoperability standpoint with the nationwide network. Get your gateway in place, and then the onboarding team can assist you in working through that process. And I've given you the names here of the key contact points for the onboarding team. Once you're ready and you're ready to submit your application, which is available on the NwHIN website, the resources that you can look for are listed here, and certainly I would recommend you go to these websites and educate yourself and attend some of these future NEHC University presentations. They have a number of those that are archived on their website. They're all very good, and the future ones coming up will be likewise enlightening. I want to let you know, I mentioned in the first presentation, as a cooperative effort here in NCHICA, collaboration among the payers, providers, vendors, government agencies, professional associations, that we do a lot of things together. And on our website, you'll find some particular tools. And I do want to point out, we've just formed up a group looking at this NPRM accounting for disclosures rule. We think there's going to be significant impacts that the vendors are going to have to provide updates, but we don't know what those are going to cost or the impacts on systems. We want to look at the policy impacts and the personnel impacts. So we have a work group that's starting. We'll be doing the analysis, and as NCHICA has done in the past, we will submit comments to the NPRM. Last thing in the box that's been very popular and a lot of downloads is our members came together and developed a decision tree and a risk assessment tool. If an event occurs, is it a breach? What is it reportable? How is it reportable? It's a very simple tool that you can walk through an event occurring. We've worked on ICD-10 and have a very significant task force there that is doing a lot of education. We publish bulletins that are available monthly, and those are available on our website as well. I'll point out here at the bottom of our face page, you'll find additional information about the nationwide network. We link to the relevant pages at ONC. We have a lot of work here in North Carolina with our Regional Extension Center and the high-tech program in our state. We've developed over the years template policies and procedures and tools to assist in compliance. And so you would find those in a deeper dive into that section. And then, as I said, as a stress reliever, we have meetings here in our office a number of times each week, and not all in person. Most of the time, the value is gained in person, but we do use web involvement, and we will be, thanks to Cisco, we'll be installing a web telepresence capability here so that our members as far flung as Maryland, Arizona, Virginia, and other places can get involved and participate in these work groups. So that's the end of that. I certainly want to hear now from any questions you might have, and hope this is somewhat helpful to you. So I turn the presentation back over to Kate.
Thank you, Holt. What a great presentation. Yes, you really covered a lot. And we do have some questions flowing in, and we've got, maybe 15, 20 minutes for questions. So, and you can still enter your questions on the right-hand side of the screen. So just to start, Holt, you touched on this, but we have one. Basically, why did NCHICA decide to connect to the Nationwide Health Information Network Exchange?
Well, that's a great question, Kate. Thank you for that. Why did we connect? Why wouldn't we want to connect if the future of healthcare is to bring information to the point of clinical decision-making? We know it's across enterprises. We know it's across state boundaries. And we know a lot of this information resides in federal agencies. So to serve the population, we have to connect. The Nationwide Network gives us an opportunity to gain insights into those standards and policies that will be required to do cross-enterprise, cross-region, cross-nation exchange. So it's given us, it's allowed us to educate ourselves, to be prepared, to be in the forefront of serving patients. And so, it was an opportunity. I'm delighted we had that opportunity and look forward to future opportunities that we can leverage off of the lessons we've learned for the future. So thanks for that question. I didn't expect the question. I thought it was pretty obvious why one would want to be a part of that. So, the way we're going to move to the future is through exchange and creating a learning healthcare system. And that's another whole discussion. And I'm really pleased NEHC took learning healthcare system as sort of, I see that as where we need to be in the next 5 to 10 years. We're building a foundation with the Nationwide Health Information Network that will allow us to exchange and use things like semantic web technology and aggregation and learn about security and policy, engaging consumers so that they have confidence that their information will be used in an appropriate way. So, we're building a foundation here with the Nationwide Network, and I think we have a great opportunity to move this whole thing forward.
Good. Holt, so we have a question on the gateway. So for your NwHIN gateway, do you use the Vangent document repository or something else?
Well, that's maybe a technical question that I can't respond to. We can get you an answer later. We're using the Mirth version of the Connect software. So Mirth has taken the Connect open source software. They've implemented it and are supporting that for our instance of the gateway. Behind that, I'm not sure if I know Vangent had a major part in getting the Connect gateway software up and running. I believe now that CGI has a contract moving that Connect software forward. I'm not certain of that, but I believe that's the case. So I know Vangent played a significant role in the early phases of this.
So we have a couple questions related to cost and sustainability, Holt. One is, so you talked about the significant onboarding costs. What are the key ongoing costs associated with the network?
Well, there are parts of that I can answer and parts I can't answer. Remember, we're talking about several components here. The cost to a community is putting their interfaces in place, building their master person index, and building an adapter so their community can connect. They will have, as new versions come out, as new standards come out, they will need to continually support their interfaces and their adapter on their side. Our contract with Mirth allows for a certain period of time they will provide updates to the Connect Gateway software to keep it compliant with the nationwide standards for interoperability. And so I can't speak to the component on the enterprise, on the community side. Depending on the structure of the gateway and the community that they're connecting to, I know that when we did an RFP for the gateway, we had 9 proposals that ranged from an initial setup of from a range of around $50,000 to about $800,000 for the same specifications for a gateway. For an ongoing cost, those same 9 vendors, the operational range from a monthly cost ranged from around $2,500 a month to over $20,000 a month. So there was a wide range. Now remember, when we're doing this, we're one of the early adopters of the gateway and early implementers. I will say from our standpoint, for our instance here, we're on the lower end of that range for ongoing operational cost. So I hope that's helpful.
That's great, Holt. Thank you. So we do have a lot of questions flowing in now, so I'm glad we have some time. And just so everyone in the audience knows, if we don't get to your question during our hour today with Holt, we will work with them offline and try to get all the questions answered and posted. So Holt, here's another one for you. Did the opportunity for your stakeholders to exchange health information with government agencies like SSA and CMS factor into your roadmap toward the Nationwide Health Information Network? And as a additional, so what is your plan for integrating those different opportunities to exchange with the federal agencies?
Another great question. I think what really drives us, and fundamentally at NCHICA, we start with the clinical need, the clinical problem. There used to be a joke among our CIOs that if they saw me coming, they would cross their fingers and say, you know, Holt, we're not looking for another technical project. There's enough. So you go get the clinical staff to make the case to our CFO and our CEO. We're excited about working on these projects, but we need support from our executive team. So when we started working with the Nationwide Network, we started with clinical leadership. We started with physicians who say, yes, my practice of medicine will be better informed if I can get information from these other sources. So we had tremendous support there. In these phase 1, phase 2 provider organizations that I showed you early really stepped to the plate with their clinical staff and their technical staff. It was a significant commitment on their part to engage. But we've all learned, I think, and are better moving forward as a community and as separate enterprises for what we learned. So looking to the future, we're really grateful to Mid-Virginia and the VA for their project in Richmond with the Social Security Administration to build a business case for exchanging clinical information to support the medical evidence needed to make determinations to number one, reduce the cycle time to then making that clinical determination that the eligibility for Social Security disability benefits. It benefits not only the patients and their families, but it benefits those organizations who may be waiting on a determination so that that patient's eligible for Medicaid in their state. So we found that there's some accounts receivable tied up. It's not a major part of accounts receivable in these enterprises, but there is information available. Now, as one thinks, and by the way, the state of North Carolina just passed a law regarding workers' compensation. Well, workers' compensation claims uses a lot of the same data that Social Security does. So if we can have providers, the burden taken off providers to support different standards for data exchange, and that's a project we're going to look at in the future, then it eases the burden on the providers to provide the medical evidence in a standards-based form. And Social Security is using the C32, the summary patient record, plus a few additional data elements to make their determinations. So once we get these standards set up, and we're sending summary patient record, the multiple uses of that information should be significant. So we're looking forward to learning about that, as resources become available, because again, setting up a gateway is an expense. And it's a commitment of time and resources on the part of the participants within the community. So to the extent that others come to the table and say, we're ready to go, here's some resources, or together we can write a grant request or a proposal to get those resources, and Chico would be delighted to team with others to take these next steps.
So, Holt, we have a question on consumer engagement. So, as eHealth evolves, what do you think will be the key success factor in engaging consumers or patients?
Wow, I'm so happy to have that question, because an omission in my presentation was to point out that as we were working through the trial implementations, and by the way, we work with DOD and Social Security Administration in that phase, but one of the use case that we bit off in trial implementations was on consumer engagement. And we work with a couple of personal health record vendors and with VA, Social Security, and some clients on how do we use personal health records in this context. At the same time, we formed the North Carolina Consumer Advisory Council on Health Information. And so they meet monthly and are our canary in the mine for us. We give them exposure to all the projects we have underway. They meet and discuss federal laws and regulations, and they've met with one of our congressmen who had a law he was concerned about for creating an aggregated personal health record at the federal level. And they gave him feedback for a couple of hours. So consumers are awfully important. We're all consumers, but having them be comfortable with the way we're handling their personal health information. And I would say comfortable means accountability in the system. I think consumers are aware, they're certainly aware with all the breaches that have occurred lately over the internet and into systems and stealing identities. They're acutely aware that mistakes do happen. I personally think that as we move the Nationwide Health Information Network forward, and I appreciate NEHC's involvement with a new consumer group, that we can engage consumers, we can engage them and educate them as to the safeguards that are built in the system. But not only the safeguards, but when bad things happen, and they are going to happen, that we have the system that holds people accountable for inappropriate actions and acts. So I think accountability is going to be the key to building consumer confidence, which will then support further rollout and use of the capabilities that we're putting in place.
Here's an interesting one for you, Holt. In addition to the lessons learned that you shared, has the group, the early adopters on the exchange, has that early group found any major gotchas? And the example provided is sort of public versus private control issues, et cetera, or has it been a very transparent? So sort of what are the gotchas or the surprises with the early participants on the exchange?
Okay, I think from a standpoint of, and I'll take it in a couple of different responses. From a financial standpoint, I think matching the cost, I think that the actual understanding that these adapters have to be built and these interfaces have to be reworked and that some of the systems are going to have to be upgraded. I think no one really walked into this realizing the intensity of that work and the impacts on these organizations. At the time, when they're still coping with meaningful use, they've got other priorities, they've got ICD-10 responsibilities. I think the upfront cost of engaging is maybe a surprise. I think as we walk through this, another surprise is, wait a minute, you mean we're going to have to pay for these connections? Who's going to pay? Where's the reimbursement mechanism? Are we going to do it on a click per pay or a subscription basis? I'm not sure that we've worked through all of those factors in terms of how do we measure the cost of the health information exchange versus the values. You know, the values to the patient, the values to the payers, the values to the providers, the lessening of risk, or the increased risk. You know, what about the liabilities? Do we have all the state laws and statutes in place to protect patients and organizations from this? I think the other part of your question is one of business. We're dealing in North Carolina with very competitive health systems. And I think in many parts of the country, competition for patients and for the dollars is significant. Well, one thing that I believe this project has shown us, and that I think our work groups and committees have done to help us in North Carolina, is realizing that really the number one job of these organizations is care of patients. So I think elevating that as a priority and recognizing, yes, there are going to be times we're going to have to share information with our competitors, but it's a reciprocal opportunity. We're going to have our competitors' patients in our operating room or in our emergency department. And as these never events keep coming from CMS, we're not going to pay for mistakes you should have known. If you had just used the connectivity in the network, you should have known not to give that medication to that patient because they had this allergy or this other medication. I think those factors are going to come into consideration that, you know, the technology is going to be there for getting information to make better informed decisions. If you make a mistake because you didn't avail yourself of that opportunity, you know, again, this is a personal opinion, but I think that's going to be a factor in our future as we move forward.
Fabulous, Holt. So we're out of time. We're going to have to bring this to a close. So thank you so much, Holt. What a wonderful presentation. And I thank the audience as well for some really very interesting questions. So thank you all. And please, before you sign off from the webinar, please do just take a moment and complete the short survey that we're going to pop up on the screen here. And we really do need your feedback, so please just take a moment and fill out the survey. And thank you, Holt. Thank you, all of you, for attending. We hope you will join us on Monday for the program, our NwHIN 304, HIT Success Stories from the Patient Perspective. We think that'll be a very interesting program. So thanks, everyone, and have a great day.
And thank you.